Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echo, vascular, general, high risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Today's guest is Laura Berg. She has a bachelor's degree. She is an RDMS and an RVT, a research sonographer at Inova Health System, specializing in advanced urogynecological imaging, going from maternal fetal medicine to a deep focus on pelvic floor ultrasound. Laura brings a unique blend of clinical expertise, research innovation, and personal insight to her work. She's contributing to groundbreaking studies on postpartum pelvic floor trauma, co-authoring textbook chapters, and is a passionate advocate for improving diagnostic awareness around conditions like pelvic floor injury and prolapse. Laura is also a dedicated educator, presenting nationally and mentoring others in the field. We're thrilled to have her here to share her journey and insights into the evolving world of pelvic floor sonography. Please help me welcome Laura Berg. Thank you, Laura, for joining us today to talk about pelvic floor. This has been a topic that's kind of come up because I have a child who's an occupational therapist and a child who's studying to be physical therapy, and friends who go to physical therapists for pelvic floor therapy. And so when I was at SDMS last year, I saw a poster about pelvic floor. So it's been intriguing to me to see this new advancement in ultrasound. So thank you, Laura, for joining us today.
Thank you so much for having me. I'm so happy to be here and get to share my newfound knowledge with the world.
Yeah, that's awesome. So I guess let's start with just some basic anatomy. Um,
Uh, yeah, so pelvic floor, when I first heard about it, I was like, yeah, blah, blah, blah. In fact, we've already probably lost a few listeners already. But I'm here to change people's minds. So it's a really complex set of muscles, but the best way to describe it is more people more familiar with the diaphragm that separates their chest and abdomen, especially sonographers. We look for diaphragmatic hernias. And the diaphragm has a hiatus. Basically, that just means the opening in which allows tubes to pass through. Well, the pelvic floor is built the same way. It just lines our bottom instead of lining the top. And it also has a hiatus, but we call it the urogenital hiatus. And then this is where the urethra, vagina, anal rectal canal pass through. And so these pelvic floor muscles, that diaphragm, attach to these structures as well, the urethra, vagina, and anal canal. And the reason this is so important is that it's part of our bodies that can get injured during vaginal delivery, but is not seen right after the vaginal delivery. So, doctors, when they're delivering a baby, they can try to protect the perineum, labia, vaginal canal, all of that during delivery and repair it right after. If they diagnose the lacerations based on how far it went. And so these injuries, are typically repaired right away. And our doctors are told to care about it because they are important, and they're told how to repair it. Unfortunately, this is not true for the pelvic floor. So pelvic floor, these muscles, also called levator ani, they can't be seen from the outside nor inside the vagina. This is like similar to if you had a baby coming out your mouth and your doctor's like, oh, I'm going to make sure that we fix your lips and, stitch back up and everything. But what they don't see is if you tore your jaw muscle off the bone because you can't see it from the outside. And if you look in your mouth, you can't see it from in there either. And so they're like, we stitch you up, you're good as new. I'm like, nope, don't promise them that because you don't know what happened to the inside. So just to kind of give an example of that in terms of actual numbers. Anal sphincter injury. So we're talking about when the laceration or cut from vaginal delivery goes down the perineum into the anal sphincter. Those third or fourth degree tears, which, you hear about because they're really uncomfortable and they cause complications. That happens to about 5 to 6% of vaginal deliveries. But avulsion of the muscle, which is when a muscle actually pulls all the way off the bone, so not just overstretching, but a full separation, that happens to 13 to 35% of women. And we're not routinely looking and we're not routinely fixing these at all.
Amazing, right? Another
Yeah.
part of women's health that we've never really evaluated or
Right,
looked
exactly.
into, right? And I like when we were offline talking before, you talked
Mhm.
about professional athletes who tear a muscle and you go right on in and fix it right away and reattach and
Exactly.
rehabilitate it. And yet women are having babies all the time with all these pelvic floor injuries that
Right.
um yeah.
No,
So
yeah.
we're just taught to deal with it, right? Because
Oh, of course.
nobody knows anything about it, right?
Well, and like women have been having babies for decades, but also
Right,
as healthcare providers, we also know like, okay, a lot of women die in childbirth. That's not like a good argument,
right,
just because, and
right,
even if they don't die, like what is that the bar? Like she survived, that
right,
shouldn't be the bar.
right, right.
Um, yeah, and so in
So
fact,
for me,
going
this
back,
was super exciting just because it's another higher level of care for women,
yeah,
right? It's like
yeah,
we can take care of
absolutely.
ourselves better even now because we have this other technology. So
Right.
super exciting, super exciting.
Yeah. So on like the athlete note, when we were talking about how athletes their muscle injuries get diagnosed immediately, they get repaired within a week because it really increases their success rates. Whereas vaginal deliveries are considered a success if they manage to get the baby out and the baby's okay and mom is stable. But
Right,
they don't really look at, oh, did she develop prolapse or did she develop urinary incontinence? They're like, no, like she had a vaginal delivery, it went great. I'm like, that can't be the only measure.
right,
In a huge point to kind of like, I don't know, a huge way to kind of point this out is the ACOG currently has guidelines on operative vaginal deliveries of forceps versus vacuum.
right,
And they say that, oh, they have equal problems, but then they cite anal sphincter injury and they say, well, forceps is slightly higher. But then they go on to say, oh, forceps has a much higher success rate. But what they didn't look at was the pelvic floor injury articles about forceps. And if you take that into consideration, probably the only reason forceps are so much more successful than a vacuum is because they're actually tearing the muscle off the bone. So before I quoted like avulsion happens 13 to 35% of the time, with forceps is 50 to 60% of the time. Like, would you go throw a ball if thought half the time your bicep would pop off the shoulder? Like, no, you'd be like, no, I'll do the other thing, please. Check.
yeah,
Like, I'm out.
yeah. Wow, that's amazing. That is amazing to me, right? Like it makes me think I need to get checked.
Yeah.
Just in
Yeah, I
case,
know.
just in case. You never
I know.
know, right? Like
Right.
you deal with stuff forever thinking that's normal and you don't know that life could be different, right? So,
Yeah. Well, right. And what's so sad about it too is that I work for Inova, which is a hospital organization in Northern Virginia. And while they do actually lots of deliveries, they handle the most deliveries in the DC region. They have the whole system has about 20,000 births a year.
oh wow.
And they have the highest level NICU, maternal care, everything. So we have a postpartum urogynecology clinic, which is pretty unique. And in this clinic, we image the pelvic floor muscles by doing endovaginal ultrasounds. And why this is important is that there's a lot of literature out there about pelvic floor injury now, but typically it's diagnosed through perineal ultrasound. So they place the transducer on the perineum, do a 3D there, just like you would do a 3D baby's face. But the only issue with that is you can't see those deeper muscles as well, and you don't get the high resolution that we get to see which muscle subdivisions have been affected. which can be really important when it comes to specific symptoms. If a patient has a rectocele, as in their rectum is falling into the vagina, it could be because the muscle subdivision called the puboanalis has been torn, whereas the rest of it is still intact.
Right.
Um, and we see these women, they come in and they're like, "Well, I found you through a Facebook group." We try to ask them who referred them. They're like, "Well, Facebook." And it's because that they've bounced from provider to provider who they say, I have these bad symptoms. I still feel like I just gave birth to a baby yesterday, and it's been 8 months. And so then they just keep digging down these, internet rabbit holes until they finally find our group. Um, and we do a pelvic exam, and sometimes we can already see something, but some signs of prolapse, and rather not the muscle injury. But then we do the endovaginal scanning and we can just show the image to them, describe the anatomy, and already, especially for unilateral avulsions where they like tear one side, we can be like, this is your normal side, this is your abnormal side. And they go, wow.
Yeah.
And a lot of these injuries, we can't even necessarily fix the muscle injuries, but usually these patients start crying, not because they're so upset, but because they're finally validated. They're
Yeah.
just
Yeah.
they're just so happy to have a provider who says, I believe you and I can show you that you're not crazy.
Right. Right.
And I don't know.
Yes. Which is huge, right? Just we haven't figured out how to fix it yet, right?
Right.
Eventually that day will come, right? Where
Right.
we can, doctors are going to figure out how to fix it. Um, but yeah. So, um, wow, a lot of questions going through my head right now. Um, so is there in your practice, is there
Yeah.
a protocol to checking the pelvic floor of a mother after delivery?
Yeah. In fact, so first we instituted a protocol actually at Inova, a clinical protocol. So that saying that, hey, women who've had forceps deliveries or vacuum deliveries, or if they have symptoms of prolapse already at 6 weeks, please send them to us because we know they have higher injury rates. Um, And then when it comes down for the ultrasound, yes, actually AIUM has a published pelvic floor protocol. And just this year at AIUM, I gave a presentation on it. Um, I went to AIUM for the first time last year in Austin, and I realized that there were zero talks on urogynecology. There's some talks on urology, and of course, plenty of talks on gynecology. But Urogyn had zero. And I looked and nobody had ever even just presented the protocol before. And
Right.
so I was like, can I just, hey guys, like, can I please just tell people about this protocol so maybe they'll do it? And the people who I, managed to round up to come to my lecture were like blown out of the water. They couldn't believe the things that we could see. Basically, we're doing musculoskeletal imaging of the female pelvis. We're doing inside, high resolution imaging, basically like a mini MRI, and actually we have better images than an MRI, of the pelvic floor muscles. And so it involves first doing a perineal ultrasound. So you take your normal transabdominal probe, you put it on a labia instead, and then you ask the patient to squeeze and see if their muscles can move towards the pubic bone. You ask them to bear down to see if they can exert force downwards and move their muscles out of the way. And then we do endovaginal scanning with that fancy linear side fire probe we have. So basically, instead of the sound coming out the tip of the probe, like a typical transvaginal ultrasound, the sound comes outside like it's a linear, but then it can rotate internally 360 degrees. So we can see the full length of the urethra, full length of the rectum, the pelvic floor muscles that wrap all the way around. We can see vaginal cysts and masses. Like I didn't know what the heck a Bartholin gland was before, and now I've seen Bartholin cysts all the time. I didn't know what a Skene's gland was before, and now I see Skene's gland cysts. I'm learning all these new parts of the body that I didn't know I had, and I'm a woman.
Yeah.
Uh,
Yeah.
and so it's been really amazing and so educational to just be a part of this process.
That's awesome. Tell me a little bit about, are there any limitations or challenges with this type of scanning?
Yeah, that's a good question. So sometimes we have people who come in for pain, and pain can be hard. We have clues, we have tools in our toolbox to try to figure out where the pain's coming from. So first, the doctor, his name is Dr. Shaberi, he performs a speculum exam to check for prolapse. But these pain patients don't necessarily have prolapse, and prolapse doesn't usually cause pain anyway. Um, so they don't have prolapse, and we're like, okay. And then he feels their muscles, and they can feel normal or they feel tight. If they feel tight, then it's likely their pain is due to pelvic floor spasm, which, for everybody listening, pelvic floor spasm, as in the muscles are too tight, can also cause urinary incontinence. It can cause you to pee when you cough, laugh, and sneeze. So just because you pee when you cough, laugh, and sneeze, it doesn't mean you need to do Kegels. In fact, if anything, you might need to relax. Anyway, um, but if the
Interesting.
muscles are normal, then he'll press on where their pudendal nerve is and to see if it's nerve pain. And sometimes that makes them jump off the bed and we're like, okay, what's the nerve issue? Um, but that doesn't cause any pain. So then we do imaging and their muscles look normal. So for people who come in for pain that we can't find any anatomic reason behind their pain, we just feel bad that we can't like help them. But we helped them in the slight way that we've ruled out a bunch of things. We've ruled out prolapse. We've ruled out this muscle injury. We've ruled out pudendal neuralgia. But then we're like, sorry, but we try our best still to provide the next steps. So we give them referrals to either pelvic floor PT if they need it, or maybe a pelvic floor or pelvic pain clinic where they can do nerve blocks if they need that. We don't. We try to do our best to never send patients home going like, "Well, this is your problem, and good luck."
Right.
We
Right.
try to provide them with the next steps. In fact, half of our patients need physical therapy because they're not good at coordinating their muscles. You tell them to squeeze and they can squeeze, and you tell them to bear down and they squeeze. And I'm like, okay, let's not, nope. So
Right.
half our patients get referrals to PT, but while we're sitting there, the doctor will just go ahead and on its computer in Epic, right, send a message to one of the pelvic floor PTs, and you're like, hey, can you reach out to this patient? And they respond back. You're like, yeah, we'll call later. We'll set up an appointment for next week. And so they leave with already a plan in place. The follow-ups are in, and so we don't want to lose them to follow up.
Awesome. Awesome. So, do you use 3D 40 at all? Like, is
Yeah.
side fire, does it spin or how does that work?
Right. Yeah, yeah. So it's I had never seen this type of 3D before, ever. I didn't even know this technology existed. So the probe we use is it's on a machine called BK. So BK Medical is an ultrasound manufacturer. A few years ago, they actually got bought by GE, but BK is kind of still their own company within GE. So they make this special probe, and their reason behind it is for surgical guidance. And so that's why it has this like high resolution. It was actually first made for colorectal surgeons to be used endoanally.
Okay.
In fact, we often use it endoanally as well. But yeah, so the image that we would typically see is a 2D image, like a linear view that you would, if you could place a linear probe up on somebody's urethra, then we'd like get an anterior view of just like a sagittal section of the body.
Okay.
But when we hit that 3D button, it rotates all the way around. So now it's firing radially all around the vagina and allows us to visualize these structures. And what's really cool is that the software on the machine, once you have the volume, you can pull it up and not just go in axial or coronal or sagittally. You can tilt the plane that you're on so that you can elongate the muscle fibers and see exactly where the tears are. You
Hmm, okay.
can, measure the volume of a hematoma. You can measure the volume of a cyst. You can track where that cyst is going. Is it actually a cyst or a urethral diverticulum where the urethra dumps urine out the side instead of going out?
Right.
And so it's this high resolution 3D imaging really gives us so much insight and honestly just surgical planning.
Yeah.
We can see mesh, we can see slings. A lot of times patients may have pain after prolapse surgery because their mesh or sling rather was too tight, or it's starting to wear through the vaginal wall, the mucosa. And so we can see that if it's positioned properly, maybe that's causing their pain. And we tell them, and of course, the benefits of ultrasound, right, is dynamic. So
Right.
we can hold the probe and not even just during a 3D, just even just 2D, to say, okay, bear down and see, make sure this sling moves properly. Because if the sling doesn't move and the patient's making pressure, then it's too tight. Yeah, and so it's honestly, I think that AIUM's protocol needs to be updated. It was only published 5 years ago, but already I've started to develop new techniques with the BK machine, including taking that 3D volume at rest, as is the protocol, but also when the patient is squeezing. So that way we can compare the size of the muscles and how big their opening is when they rest versus squeeze. Um, this can tell us more about what's going on with them. So you have people who at rest, their muscles are really wide and really long. They're just open. But when they squeeze, it goes all the way back to normal.
Mm.
So what this tells us is that their muscles are probably intact. They're just stretched out.
Um,
And maybe, they're having prolapse not because of the muscles being injured, but because the support of the uterus itself failed. So over time, like an abdominal hernia, the muscle wall opens and the bowel pushes out more and more and more, even though there's no muscle defect, it's just that it makes the muscle weak and stretch out. But if you can fix the prolapse, fix the hernia, then the muscles can go back to normal and do the normal function.
okay.
And so this is also basically the idea behind pessaries for urogynes,
Right.
is that you push it back up and now the muscles can do their job.
Uh,
Um, but of course, then we have the problem where we scan a patient and we do the 3D and we can see the muscles are torn. So now when we do a 3D while they're squeezing, it's the same measurement. They can't flex, you can't flex a muscle that isn't attached to where it's supposed to go.
right.
Um, and for those patients, the doctors can still try to fix their prolapse, but it will not return muscle function.
Huh. Interesting. Yeah, the pessary is just to give it support, right? It doesn't really change
Correct.
the muscle, right?
Correct. Right.
Interesting.
So they found that if people are given pessaries, it can help aid, like fix prolapse a little bit. So if a person wears a pessary regularly, I think because it then allows the muscle to have the normal function, and then you can strengthen them back up again. Then when they check their prolapse again, it's not as bad because now the muscles aren't stretched out. But going back to people with torn muscles, in fact, somebody did a study showing that women who have a problem with whether a pessary expels, it just comes out. They can't, they have to keep trying to put it back in.
Right.
They're much more likely to have an avulsion because there's no muscle holding that pessary back, and keeping it above that,
Avulsion, the
the
muscle.
muscle separation.
Yeah.
Yeah. Yeah.
Wow. Huh.
Yeah.
Interesting. Yeah.
Yeah, and so mostly I'm just really just trying to tell literally everybody I can about this type of injury and how it happens and get more people to care about it, get more people scanning it, so that we can study it more and
Yeah.
learn how to prevent it and learn how to fix it. In fact, we were at the beach recently and I told the jewelry store owner all about pelvic floor injury.
I love it. Right? You're so passionate about it. Well, it's so exciting, right? To be able
Yeah.
to fix something that you've heard your mother or her
Yep.
girlfriends talk about, or at my age, my friends talk about,
Right.
and sometimes we don't talk about it because it just seems to be okay, that nothing to do about it, like to
Exactly.
be able to start a conversation to say, oh, there's a solution. Let me refer you to or
Correct.
get some information from or about, and
Right.
um,
And that's, yeah, and I do want to highlight that. While we can't really fix muscle injuries, there are a lot of solutions for fixing prolapse symptoms, urinary incontinence symptoms, stooling issues, sex problems. And so if you have pain or problems with peeing, pooping, and sex, please, please, please go see a urogynecologist. And it doesn't have to be surgery. I mean, there's pessaries, there's pelvic floor PT, there's neuromodulation where they can put a little chip in your foot, in your nerve, in your leg, and then they stimulate it with a needle, and it's the same nerve as your pudendal nerve, and so that I can actually help bladder symptoms. Yeah,
wow. That's
No, and
awesome.
oh, there's also what's it called? TENS units, but it's the e-stim.
Hmm.
But there's intravaginal e-stim that you can buy like on Amazon.
Oh,
And so if your muscles are kind of too weak because like the nerves are shot, but you want to keep your muscle strength strong, you can do e-stim.
oh,
Um, so there's lots of options out there. And so I don't want people thinking like, oh, there's no way to fix this, it's only surgery. It's like, no, no, no. Like just go get an opinion, see what your options are, and you don't have to do surgery even if they say that's your only option at this point just because of how bad it is or your symptoms. But at least go figure it out. That way you don't feel like you're crazy. You're gonna feel heard, you're gonna feel seen. Um, and then when you're ready for surgery, you can get the surgery.
yeah.
Um,
If
but
it's
just don't live
needed,
like this. I mean,
yeah.
so many women, they just live like this for a long time. We had one patient who she tried to see colorectal. She went all over the place. She kept having to wipe poop out of her vagina every time she went poop. She thought it was just like kind of coming up from around her perineum. She thought it was just like messy.
Yeah.
But on ultrasound imaging, we found a fistula.
Yeah.
She had been dealing with it for 6 years.
Yeah.
And
Mm,
we're like, hey, guess what? We found it and we can fix it.
yeah.
It was huge for her.
Yeah.
Um, Yeah, and so I mean, this field is rapidly evolving. Urogyne is a very new area, but like, there's still a lot they can do already, and I think there's a lot more to come.
Awesome. So I'm going to circle around back to this question of you said forceps or vacuum, right? For
Mm,
delivery. I
yeah,
understand the forceps, right? Because you're going in and kind of spreading the muscles in order to grab the baby and pull the baby out. But for a vacuum, I thought they just put a vacuum on the top of the baby's head to help pull the baby out. How does
correct.
that destroy the muscle?
Yeah, so I gotta be honest, I'm not really too sure about it either, but I think it's more just that. So forceps, yeah, I think it's just like forceps are just bad because, like you said, it's like you're adding all this extra pressure. You're adding yet another thing between the baby's head and the muscle.
Right.
I think the issue with vacuum is that the baby wasn't coming out spontaneously, and now you're forcing it to go past the muscles.
Oh, I see.
So I think there wasn't another way to get the baby out without an operative delivery. It's just that people should know that if they ended up with a vacuum, that they may have pelvic floor injury. It's
Oh,
not to say the doctor shouldn't have used it. It's just that it's just something that happens. Same thing with spontaneous deliveries. Some women do just fine. And some women, even in spontaneous deliveries, like their baby wasn't going past their muscle, but they were so effective at pushing that they just pushed right through it anyway. Um,
you
and so
said
going back,
a lot of times athletic girls
that's
have
right.
more because they're so strong that they can
Correct.
push through the
Exactly. Yeah, so they'll come to us, we're like, do you consider yourself and like, athletic? And they'd be like, well, yeah, I guess. We're like, well, what do you do? Like, well, I ran a marathon, during my pregnancy, and I deadlift before that. And we're like, okay, so clearly you're athletic. They'll like be modest at first. Um, but yeah, so they're just so strong. Their abdomen is so strong, their diaphragm's so strong, everything's so strong that when they go to push, they just blast the baby out. And they'll be like, I pushed out in 10 minutes. We're like, okay, but then now your muscles didn't have any time to stretch. So that's maybe why it popped off the bone. And so how I like to describe it too is like, if you pretend that in order to have a baby, you needed to touch your toes with your elbows and but your hamstrings get in your way, right? Because they're pulling on the opposite direction.
right,
But if you take your time and your hamstrings are pretty flexible, like you're already pretty good at touching your toes in general, then yeah, you can probably get to your elbows over the course of 2 to 3 hours.
right,
But if your hamstrings are really tight and then you try to touch your toes, you're either not going to make it, in which case you're going to need operative vaginal delivery or a C-section, or you're so strong in your abs that you overpower your hamstrings just by going as hard as you can forward, and then your hamstrings just can't take that kind of pressure, that
no,
kind of strain, and then just come off. Yeah, and I do want to illustrate actually, avulsions are specifically a grade 3 muscle strain. And so that is a complete separation of muscle off bone. We also see a lot of grade 1 and 2. And what's important to kind of underline is that those injuries are not considered avulsion. So when you're looking at literature on this and they talk about avulsion rates and how to prevent it, the grade 2 injuries still have significant impact
Okay.
on somebody's, their genital hiatus, how big that opening is, and then therefore the prolapse developing, um, and also muscle strength. So some of the injuries we can see are individual fibers tear within the muscle, and it can create a hematoma within the muscle fibers that can't escape. So now it's like you're trying to use your muscle or like flex your bicep, say, with a golf ball in it.
Okay.
And if you have another vaginal delivery and it happens again, now you have more golf balls in your bicep because those hematomas don't actually go away. They
Away.
get replaced with these like fatty and fibrotic changes. And this has also been published in like musculoskeletal ultrasound images.
Okay.
Um, and so the more and more you do that, it's just the weaker the muscle gets because it can no longer contract as strong as possible. Um, and so another thing that we're trying to illustrate to providers as well as the patient population is that you shouldn't have this idea of, well, I already had one baby vaginally, I may as well just keep ruining the same way. It's like, no, don't think that way. Because if you're a baseball player and you tear a muscle in your arm, say a part of your tricep, your doctor is not going to say, oh, keep throwing with that arm. You already ruined that side. Well, no,
Right.
because now you're going to tear something else.
Yeah.
You don't want to get rid of whatever function you have left.
Right. Oh, it makes so much sense when you talk about it like that, right? But yeah, we've never had the opportunity to talk about it for women, right? We
Yeah.
don't know any different. And
Right.
so it's exciting to know there's another way to look at it. And just like anything, right? You need a doctor's order in order to get this exam
Right.
done.
Yep.
Um, but the fact that it's out there, like when I saw the STMS, there were students from Mizzou, my alumni place, that actually did a study and the big poster on pelvic floor. And so when I looked at that and uh, kind of started to investigate it on my own just a little bit, I thought, okay, so they're doing this in more than one place. Okay,
Right.
so this is starting
Right.
to be a little popular, like this is a
Yeah.
new area, this is a new thing.
Yeah.
Um, so yeah, I think
And,
getting the word out and seeing how different people do it and different things, and pretty soon we'll have a solution and a surgery to fix the muscle, hopefully, right?
yes. Yeah.
If they can fix biceps and triceps and all different, hamstrings and all different kinds of things. I'm sure we can figure out how to fix this too,
I mean, honestly, that's how I feel about it. I mean, this is just my personal take, but like, they often don't want to fix prolapse, or do a prolapse surgery until women are done childbearing, which makes sense, right? Because half
Right,
the time it involves removing the uterus, and resuspending the vagina, resuspending the rectum, all this repair that causes a lot of scar tissue.
right.
However, for muscle injuries, like athletes, they repair it right away because then that way the muscle doesn't atrophy. It doesn't scar and reattach somewhere else lower down. They can put it back and then they can strengthen it again. And, women, when they have even a vaginal delivery, are going to be in the hospital for about 2 days. So I think this scan should be done after every vaginal delivery because there's no delivery that's not high risk. I mean, 20% of people tear their muscle off the bone. That's really high.
That is
If I was
hard.
gonna go in a boat, but you told me 20% of the time I'd have to take the lifeboat, I'm like, nah, I don't want to do that.
Yeah, exactly, right?
Like they're going, well, you're not gonna die. I'm like, yeah, I get it, but that doesn't sound fun. So no
Right,
thanks.
right. Exactly.
You know? And yeah, I just think that it should be just fixed immediately while they're in the hospital. Get a musculoskeletal surgeon in there to repair it, and then monitor them for the next 2 days in the hospital.
Hmm. So you think it should be monitored immediately after delivery,
Yeah.
or do you give it time after delivery?
No, we found that injuries that we see immediately after delivery pretty much look the same 6 months later, except the fresh blood is gone. The hematomas are still there, but the fresh blood is gone.
Oh,
So where the muscle falls immediately after delivery is where it's going to stay. It just reattaches lower down. In fact, I was on Radiopedia, as you know, because you can find cases there.
right,
And I was trying to understand MRIs better.
right.
So I was looking at a pelvic MRI and it said normal pelvic MRI. I'm like, okay. So I'm looking at it. I'm like, no, she has avulsion. They don't know it. It's just in everything. And sure enough, one side's reaching all the way up, the other side is, falling down. And sure enough, when you look at her bladder in the MRI, her bladder's all also down to one side because it's no longer being, held up.
Yeah.
And so it's so prevalent and so under like I don't know under how do I say it? Educate. I don't like what am I talking about? I'm starting to lose my brain. Um, it's
No,
it's it's
yeah.
just not enough people are trained on
Underutilized.
it.
Yeah.
That
Available.
even
People don't know that it's available.
exactly well people don't know about this at all, including doctors, including radiologists who look at this MRI and call it normal. It's
Yeah.
not normal. If
Right.
you had an MRI of a patient's arm for some other reason, but the bicep was now halfway down to where it should be, you'd probably mention it.
Right.
But it's not anatomically where it should be anymore.
Well, it's an interesting combination of GYN and muscular skeletal,
Right. Yeah,
right? Like, what a
exactly.
unique crossroads between these two specialties, right? Because I'm sure you could probably scan a bicep and see some very similar um, anatomy
Hmm.
or abnormalities in the bicep that you're seeing in the pelvic
Right.
muscles, right? Because you're looking at muscles, right?
That's right. That's right. In fact,
So it's
when I went to
interesting how these specialties are kind of starting to cross each other to make their own unique um, specialty, really.
right. Yeah, so what was and so when I went to AIUM this past year, they had a pre-conference course on musculoskeletal scanning. It was for the upper extremity. And I'm like, well, I don't actually scan MSK. I don't do arms. And
Right.
so, but I still wanted to learn it, so I volunteered as a model.
Okay.
And so then I could learn the principles while they were scanning me. Now I also have Ehlers-Danlos syndrome, and for people who don't know what that is, it's not actually a collagen disorder. It's a disorder of the connective tissue that affects the extracellular matrix. So everything that holds up all of our cells and keeps them in place, mine's too stretchy. So while they're scanning my arm, they found that my ulnar nerve subluxates around, around my joint. They found ganglion cysts in both of my wrists. They're like, oh, look at this. This is fun. And so it was fun for them too. But anyway, so while I was there, I was talking to some of the doctors and the sports med guys, who do these surgeries for
Right.
MSK.
Yeah.
And I was like, hey, so how come you guys don't look at the pelvic floor? Like even bought an MSK textbook and it lists basically how to scan every single muscle on the body except for the pelvic floor, which is once again a voluntary skeletal muscle, just like all these other muscles. And he was like, oh, we don't do that. I'm like, well,
Why not?
that's
Yeah.
that's not an answer. Like,
Just because medical school didn't teach you doesn't mean that you
exactly.
couldn't figure that out. Right.
Right. I
Yeah.
know. It's like they don't have like a curious bone in their body. It's like, don't you want to change that then? Don't you want to include another muscle in your musculoskeletal practice? No.
Oh, it would open up big time if they ever figured out how to fix it, right? Like
Exactly.
he'd have a
Oh,
waiting
huge.
list full of women.
Huge.
Yeah,
Yes.
yeah. He would build, yeah. Somebody
Hmm.
somebody will eventually, right?
I
So,
know.
if you can fix a bicep or a tricep, you can fix a pelvic floor muscle too, right?
Right. Well, so that's, yeah. So part of the issue is the type of injury it is. So when the muscle pops off all at once, it leaves the muscle itself pretty much intact, even if it did fall down. If it got stretched and stretched and stretched and then came off, now the muscle has been shredded. Um, So what Dr. Shaberi has found that what we see on ultrasound does predict surgical anatomy as well. So if we can see a big muscle bulk, even if it's not in the right place, he can see that on surgery. But if it looks shredded on ultrasound, he's not going to be able to kind of find all the pieces and put it back together. And so this is why, of course, going back to prevention is so important. You
Right.
know,
Right.
I really think that women just need to be taught how to bear down properly, and if they have a tight pelvic floor, to be going to PT before delivery to
Yes.
show them like how to relax these muscles and how to stretch them properly.
Right.
Um, but that's another thing that we underdiagnose is women with tight pelvic floors, women who have sex in pain, who can't poop because their pelvic floor is too tight,
Right.
who go to their pelvic exam and are so scared of the speculum because they know it's going to cause pain because their muscles are tight, but then that causes further spasm and makes it even more painful.
Right.
But instead, the doctor's just like, you need to relax. They don't send them to PT.
Right.
And so we need to be capturing those people, diagnosing them, and sending them to PT and seeing if we can help them out.
Yeah. Yeah. And I think that's the key right there, right? Is prevention,
Oh
right?
yeah.
How can we, and I think I mentioned this to you before, like I think sometimes midwives have techniques where they can help stretch that lower segment or that muscle
Right.
or perineum, I think you were talking about, right?
Exactly. Yeah.
Mm.
So perineal injuries, and Inova does do their best to practice this. There's something called Safe Passages, which is like a program designed to help protect the perineum and stretch it out. And so yeah, so that is definitely taking off. They found, I think, some improvement with perineal injury rates with that. Um, but what's different about the perineum is it also has more connective tissue compared to like the pelvic floor muscles itself, and so that's why I think it can't stretch as easily. Um, but going back to that, the perineum, oh shoot, oh yeah, the patients with tight pelvic floors also have higher perineal injury rates as well. But outside of that, if somebody has a bad laceration, it doesn't predict the inside. And similar, if they have a normal outside, it doesn't mean that their inside is intact. So you can't just assume that, oh, the outside's fine, the inside's gonna be fine, or the outside's bad, oh, the inside's probably bad. It's like, no, you need either way, you just need to look.
Right. Right. That's amazing. I'm so excited because I think a new prevention, right? A new
Yeah,
prevention will be starting to be practiced or evolve anyway from
hopefully.
a lot of this, right?
Yeah.
And getting the word out and getting the training out for people to be able to know what they're looking at and be able to do pelvic floor imaging
Mm-hmm.
correctly and thoroughly and just also, having contact people to reach out to, right? Like I know when I was learning fetal echo, I had a person who did pediatric echo. And so her and I would compare notes, and I'd say, okay, this is what I saw. And she's like, okay, well, this is what we would do if we saw that. And I'm like,
Oh,
okay, and so,
yeah,
it was wonderful to have someone to bounce ideas off of or send pictures to and say, okay, tell me, what do you think? Here's what
right.
I'm looking at. This is what I'm thinking. Am I right? Am I not right? So,
Exactly.
um,
Exactly. Or like I'm running into this issue. Yeah, like what should I do? In fact, that's also nothing that, I like you said, the MSK of the pelvis, it's just like one of the things I had to learn was the concept of anisotropy, which I didn't know was a thing. And those who do MSK already know, and they're like, well, you're an idiot. But basically, it's the concept, we all know that, when you're scanning bones on a fetus, that you get the best image when the ultrasound beam is perpendicular to the structure you're trying to see, right? Well,
sure.
it's the same thing with muscle fibers. But
Yep.
with muscles, when you're not perpendicular, it's not just slightly a little bit more gray, it's like black. And so you have to know that like, okay, no, that's just simply my angle of inclination. That is not pathology.
Pathology. Yeah.
And when we're doing these volumes, and you're looking at the images after you take the volume, you can't change your angle of insonation.
Right.
In your brain, you have to just go, okay, I'm at this area of the pelvis, and the ultrasound beam is coming out radially from the center, and this is the angle. So this part of the muscle will look bright, this part of the muscle will look dark, and know that it's the same muscle fiber,
Okay.
rather than thinking it's a different part of the anatomy,
Right.
or
Yeah.
pathology.
And so to have that, like, this is part of the reason to have a podcast is to create community. Like
Right.
somebody who's doing pelvic floors at Mizzou in Missouri can call someone in Maryland, yourself, and say, "Hey, can we collaborate? Can you look and tell me what your thoughts are, or have you seen this before?" Or
Yeah. Yeah.
right.
In fact, so the doctor I work with, he just started we have a nationwide postpartum urogynecology consortium for people who do postpartum imaging. So yeah, if you have a clinic or know somebody who does, please reach out to us. And we can, get you guys collaborating and meeting with us on this clinic.
That's
And
awesome.
it is to curate, to update these guidelines, to provide more recommendations, to hopefully change some guidelines.
Right.
Um, you know, try to improve women's health.
Absolutely. I love it. Nothing better than getting the word out, creating community, increasing better health care for women, especially since we are that, right? Um, and men too, but we've had so little research for women in these
Yeah,
areas that to be able to put a spotlight on it finally. And like you said, just validate people for not going crazy. You're not going
yeah,
crazy. There is something going on, you know, and
yeah,
that's so awesome. I'm so excited about this. Thank you so much for sharing all your expertise and knowledge and your passion. I love that you get excited about this. It makes me kind of giggle and think about myself a little bit. And
yep.
I was talking to coworkers today, and I'm like, I'm so excited. I'm going to record this podcast about pelvic floor. And they're kind of looking at me cross-eyed, like, all right, whatever. And
Well, I know, but that's how I used to feel about it too. But then it's like once you start reading about it and learning about it, you're like, oh wow, this is actually a huge problem, and we can fix it
right,
because we just need to elevate it to where other modalities and other specialties are.
right. And so then now this is going to become the norm, right? We're going to do
Right.
this on a norm to fix and put your body back together, right?
Exactly.
So
Exactly.
awesome, awesome. Thank you so much. I appreciate it. Oh, one
Thank you
last
so much for having me. Oh
question
yeah.
I try to ask my guest. I've gotten away from this, so I want to try to get back to it. Is the name of the podcast is all about the frequency.
Mhm.
So, in a time when you're not at your highest frequency in life, what is one or two things that you do in order to increase your frequency or to
Yeah.
be in a better mood?
I gotta be honest, I love being outdoors. And we live right next to some national trails. We're right next to Great Falls, and so I can go up the street and just get my mind off everything. In fact, this week I probably could use that. So I'm so
Yeah.
glad that you.
That's awesome. Nature
But yeah,
is,
backpacking, hiking, camping, love it all. With kids, it's been a little bit harder, but we've already taken them camping a few times as well. And
that's
that's
awesome.
just my other passion is just the outdoors.
Yeah. That kind of refuels you. Yeah.
Yeah, and
Me
well, it
too.
just resets me, like especially when we go backpacking and there's no cell phone reception.
Yes.
You
That's
you
the
you
best.
can't, right? You can't
Yeah.
check your phone. There's nothing to check.
Right.
And so then you're just like, oh, okay, I'm okay. Like, like this is.
Presence. I'm
Yes,
here.
yes,
Right?
yes. Yeah, I'm here. My body's okay. I'm happy. The sun is shining or it's raining, but whatever, I'm here.
Yeah.
And, like tune out the world for a little bit. And it really does just kind of help center and ground you again.
Absolutely. I love it. All right. Thank you very much. I very much appreciate it. And we'll talk to you again soon.
All right, great. Thank you again for having me.
Thank you for tuning in to It's All About the Frequency podcast. I hope you enjoyed today's episode. Share it with a friend and remember to keep your frequency high.